Hi everybody, I'm Laurie Cadden and we are at Northeast
Turn.
I love it. Northeastern. I know I was getting see Chris already. I love it. So we are here at Northeastern Rehab. It's a great facility. It's over on the bottom of the Morgan Highway. The old, you know what this building used to be? Bardakowski's. Do you remember
really?
that?
No.
Long time ago. Chris Connor, DO, I love it, is here because he is a physician with Northeastern Rehab and he specializes in pain management. And we're here to talk a little bit about what pain management is, how it can help you, why people need it, and this is what you guys do here, along with rehabilitation and everything else that goes along with that, Chris. So welcome back to the region.
No, thanks.
He's a Forest City guy. He's told us. Just got back. You finished your fellowship in the summer, and you came back. You joined here in August.
Yep,
and how are you doing so far?
Good.
You
Enjoying being back in the area. So.
When you went to medical school, did you think I'm never going back there?
No, not actually.
No,
actually,
you thought
as
you'd
a
come
med
back?
student, I rotated here. So.
Okay, so you thought this would be good for you?
I always thought it'd be an opportunity, possibly again.
Okay, and I'll tell you, these doctors get cuter by the day. Honestly, your beautiful eyes, good-looking guy there, and smart too. I love it. So, Chris, what is pain anyway? Explain.
Sure.
Oh, I have a pain in my. What causes it? What is it?
So, start with just the definition, right? So, pain is an unpleasant sensory and emotional experience due to actual tissue damage or perceived tissue damage. So kind of breaking that down, right? So you stub your toe or you break a finger, right? That's you have pain in that area. But there's also sort of a subconscious emotional experience that goes along with that you don't control, and it happens no matter what. And then if once pain starts bothering somebody a little too long and it becomes more chronic, there's you have pain even when the broken finger or the stubbed toe is healed. So that's kind of the perceived tissue damage. So, it's.
And how about nerves? How do they play into the tissue? Because they're all wrapped in that. Is that what happens?
So nerves are what we have nerves all the way from our fingertips, our toes, all the way up to our brain and in our spinal cord. And what the nerves do is they actually sense the pain, right, out in the limb.
And it's telling you that it hurts.
Yeah, and then it kind of sends the signals to the spinal cord, that goes up to the brain, and then we feel the pain.
So Chris, is that why we're going off the track here a little bit, but is that sort of why, and in your as a DO, how you're trained, is that why it's always important with what you do to the mind and body is so closely related or connected because of something like pain, where you can help the mind a little bit work with the pain somewhere else?
Yeah, and exactly. So we've, many years ago when somebody was in pain and it was lasting a little too long, or oh, that's all in your mind, right? Well, they weren't too far off, but just in a kind of a different light, right? Now we're learning that when somebody's in a lot of pain, it really does affect how the brain perceives it as well, and there's actual changes that occur in the brain. So everything is kind of related, brain and body.
So tell everybody then what the difference is, and you sort of touched on it, the difference between acute pain and chronic pain.
So acute pain, like we talked about, right? You break a finger, you stub a toe, you touch a hot stove, you have surgery, right? There's a certain area of the body, there's an issue, right? There's a start and then there's an end. There's a normal kind of inflammatory response and healing, sort of start and finish. Chronic pain, unlike when you normally would have a kind of a finish to that pain, like the broken finger heals,
right.
The chronic pain kind of continues on. And what we've learned is the reason for that is like a complex kind of cascade of effects. So we have issues that occur kind of at that nerve level, like we talked about, in the finger or the arm. There's changes that occur in the spinal cord level, and then even the brain. So that's kind of what perpetuates this chronic pain cycle. And it could even get so severe to the point where you have pain from me just touching you. And that is kind of because your nervous system is all revved up in this kind of like cascade of chronic pain.
So tell everybody some of the problems associated then, I guess that's one of them, with a chronic pain. So is there an actual illness that touching, isn't there?
Well, so there's such things as maybe fibromyalgia or different things like that, where we've learned that these are kind of more widespread kind of chronic pain type issues for different causes. But there's there's a whole host of, chronic pain is a syndrome in and of itself. Usually there's a cause to it, and we always like to figure out what that cause is first while we go on to treatment. But yeah, it becomes its own whole syndrome, its own diagnosis.
So tell me, what you do, is this more of a, I remember years ago, I'm 55, so think about all those years ago. How more popular, so to speak, or how more relevant or needed, let's say, is what you guys do in this world of all of the things from athletes to injury? The more active you are, the more, and you really need help with pain, regardless of who it is, how it is, they have to get beyond that. Yeah. So how do you think this has evolved more recently in this profession than, say, 20, 30 years ago? Has it?
Yes. Okay. Short answer, yes, it's evolved quite significantly. So maybe 20, 30 years ago, our treatments for patients who were in kind of this chronic pain were very limited. It was mainly anti-inflammatories and kind of pain medicine, right? Now we have a whole host of treatment options that really, as the technology gets better, as all that kind of stuff continues to grow in the world, so do our treatment options for chronic pain. So
which is good for everybody now, right? With all these, so many people are doing so many different things, and exercising, getting hurt. They're real type pain, and that's a neat question too. How do you determine, because one of the questions is, do I tell a doctor I'm having pain? Well, we would hope so, but is there chronic pain? Like they're saying, I don't know what's wrong, it's this. Sometimes it boils just down to, okay, you know what, you're getting a little older, things are happening. Do people say, I live with it, I wake up every day, I live with pain? Do people have to live with pain?
So, we see a lot of patients like that where they might, be dealing with the same issue for years on end, right? And they've been able to deal with it, and it's a part of normal living, right? Aches and pain type thing.
But as you get older.
Yeah, so that happens. But what we really try to focus on is if that pain starts to limit you functionally or stops you from doing things you enjoy, whether it's playing with your kids, grandkids, going out, riding a bike, running, or even going to work, things like that, that's when I definitely think pain should be addressed.
And does pain always come with some type of pain relief? Always come with some form of medication, or can it be through manipulation and different things? Like we have so many charts here and muscle groups, and how does that work?
So there are a whole host of treatment options for pain, and medication is just sort of one treatment arm, and it's one of, at least myself and I'm sure many other docs, one of our least favorite, because of all the side effects and things like that.
And the addictive nature of something.
So if we talk about opioids, the very addictive nature and the whole issue that's going on right now in our country. But some of the other treatments that we often employ are more of a physical medicine approach, so whether that's therapy, massage, acupuncture, chiropractic care, those kind of things for certain conditions have been shown to be helpful. Other conditions, there's different types of medications other than pain medicines we use. And then there's also certain injections or minimally invasive techniques that we do, often under X-ray or ultrasound guidance, that can be helpful for patients.
When do you decide that you may need an injection? Like say you're someone who thinks, I don't know if I might have this issue and I don't want surgery first, I want to try these alternative methods. When is it decided that maybe an injection versus just plain old physical therapy? Does it depend on the severity of the injury or the problem that then determines how you make the rehab easier? What happens then?
Yeah, so actually a lot of the patients we see for numerous complaints, whether it's knee, hip, back pain, neck pain, shoulder pain, they've often tried physical therapy already. And the patients we end up seeing, a lot of them, physical therapy just didn't cut it for them, or it helped them some but just not enough. And that's where some of these other kind of interventions come in, so injections or things like that. And that's the kind of the conversation we have with patients. We kind of review what's already been done, and oftentimes, what we have to offer nowadays as technology's gotten better are things some patients haven't even heard of, so that's why it can be useful.
How about that old, and I don't even know if it's still around, that TENS unit, does that still exist?
TENS units still exist.
And do people still use them outside of being treated here? Or,
they do.
Like, I used to remember seeing someone with it on the back of their neck and think, what is that?
TENS units can be really good for some people.
What does it mean? What is the...
It's just electricity. So we're kind of stimulating some muscles. At its most basic form, it's the body can only kind of take in so many sensations at one time. So we kind of give them a different sensation that is somewhat enjoyable, and it kind of blocks out the painful. And it's interesting you mentioned that, because now with the technology topic, we've actually started to take kind of TENS-like units, and now we actually are able to put them right over top of the spinal cord. So we actually use electricity kind of a little deeper, so to really treat a lot of chronic back and leg type pain and stuff.
Do you feel that, and this it's based on the patient, but do you feel that back issues are like almost the most chronic, really problematic for people because of the movement everywhere, the sitting, the getting up? It seems like at least I know friends who happen to have back pain. It seems like it is so crazy and debilitating versus some pain somewhere else where you kind of can use the other, hey, it's all right, I have another leg, but you don't have another back. So does it sort of go there because of arthritis, or what happens?
Back pain is a very challenging and very important thing that causes a lot of pain in patients. And I might be a little biased, but I do think back pain is one of the most difficult things to kind of treat for patients. And you think about all the weight the body holds, right? Everything is kind of going through that low back area, and every time you're making a movement, you're putting stress through the low back and the joints.
Is that what it looks like behind you? Can we show them that? So that is what the spinal cord looks like, the spinal column.
Yeah. This is what it looks like here. So you have your iliac crest, kind of those wing bones down on your hips down here, and then we kind of work our way all the way up. This would be where the top of your neck, and oftentimes in this area down here is where a lot of the low back issues come into play, kind of in this little area. So this is considered a fancy term called like lumbosacral region, right? So the lower lumbar segments, and then your sacrum, so kind of your butt bone here. And it's only a little part of the body, but this region right here causes a lot of issues for a lot of people.
What if what's this, I forget.
Your coccyx
bone.
Yeah.
What if someone breaks that or chips that? That's extremely painful, right?
It can be very painful.
Do you do pain management for that too?
We have at times, yeah. So there's a little joint right there, and sometimes this can be kind of displaced or kind of bent a little bit, awkward from a fall. So sometimes it's as simple as kind of going in under X-ray, because it's kind of hard to find just by touching back there, and we put a little steroid and numbing medicine in and calm things down so patients can sit at least. And
what would these be then?
Oh, so a good question. So these are your nerves as they come out. So
nerves.
You have your spinal cord that comes out from the brain, kind of comes all the way down in the center here. You can kind of see deep in there. And then at each level you have nerves that come out from all the way up top all the way down to the bottom. These nerves then travel all the way down your arm or all the way down your leg. And these are oftentimes what in patients who you might have heard of, like a herniated disc or like sciatica.
Yeah.
That's the issue usually with a patient who's complaining of sciatica really is coming from one or maybe two of these type of nerves up here in the spine.
And that's the one that runs down the rear and down the back, right? Or
Sciatica kind of down the rear, everybody talks about it, but you can have similar issues when it kind of wraps around to the front, just depending on which nerve it is.
And tell this section here, these disky, whatever. What are they considered? What are they?
Yeah, these
are they discs?
They are.
So that's
good.
what slips or moves or breaks down. So when you have a slip disc or a herniated, do they actually collapse onto the bone to bone, or what happens?
It could with time. You kind of see shrinkage and the space between there, and that happens with normal living. That's a normal process. But you kind of see this little reddish orange thing here. That's kind of to mimic what a herniated disc would look like.
Oh, so there's then a bulging, just like herniated.
And this could occur out here, and it would hit this nerve root as it comes down, or it could occur deeper in there, kind of right in the center, and push back on a bunch of nerves.
And is a herniated disc caused from an injury, or can it just be for any other reason?
So usually we see a lot of patients with injuries.
Okay.
One of the other, kind of wear and tear, and one day all of a sudden you're just lifting something and you stand up and there it goes, and all of a sudden you have pain and weakness in the leg.
And that's what it's from?
Yeah, it could be.
That is, I didn't realize okay, so then it bulges out. So what's the treatment for that? Is
Sure.
the same thing then, the rehab?
Well, yeah, so it's, it's kind of like a stage process, right? We know a lot of people who have a herniated disc get better relatively quickly, right? The first couple weeks, not too pleasant, but with some therapy and maybe a little anti-inflammatory kind of rest type activity, they feel better and they're able to go on with their normal lives. The disc herniation might still be there, but it doesn't cause them problems.
So it could be chronic though, right?
Well,
because
yeah.
if it goes back and you're okay, and that you reactivate it or something
Well, yeah,
happens.
and for whatever reason, some patients, it doesn't get better on their own.
Mm-hmm.
And they're the type of patients that we see a lot of the times.
Okay.
And then we start talking about, well, maybe, could an injection such as an epidural be helpful? If you haven't had good physical therapy, sometimes we just need to prescribe a little more appropriate type physical therapy for patients. Not all physical therapy is created equal. We also talk about maybe some nerve type medicines that can be used. And then we kind of reserve it last, but in some patients, surgery is what's needed. So, and then we get them off to the appropriate people.
So in light of that then, we kind of touched on it a little bit earlier about the opioid issue that we have. So from your standpoint, that's probably your last resort if that's something controlled that you need to, you find from everything else you're doing, hey, this isn't working, they have to have some type of other pain management through drugs. So what is your take in this industry and what you do on this issue with opioids, and how do you try to really pay attention, because there's so much of it now?
Sure, yeah, and that's a very important topic to talk about. So maybe years ago we were a little more liberal with giving pain medicine out because we didn't know of all the risks that were associated. And now, unfortunately, we've learned that with kind of chronic use of these medicines, there's risk of addiction, abuse, misuse, diversion, where people kind of falls into the hands of the wrong person, and then the overdose and death, right? So really the way my practice and the way I look at using these types of medications, they really are a last resort for a lot of options, because there are numerous other treatment options out there. Using that as a last option, some people, they help a lot, and other people, the risk definitely outweighs the benefit.
Yeah, because I think it's really important, because people can come to you and say, I'm not getting any better. Whether it is or not, you have to rely. That's an issue. You have to take what they're telling you seriously now, which is so different from how it used to be. Mm-hmm. Now that's part of your training, isn't it? People with pain have to be paid attention to.
Well, yeah.
Because you never know.
No, and they should be.
Right.
But unlike high blood pressure, diabetes, those are all things we could check.
Exactly.
So
from blood work and other stuff.
And this is why, to me, pain is one of the most complex and hardest things to treat in our field, because it is subjective. We don't have a measure of, okay, they're
that's
in
what you're doing.
severe pain.
Pain all the time.
Yeah. So what we kind of rely on is really sort of that patient, doctor, or primary provider relationship and kind of interaction, right? Looking for objective causes for pain. Are there things that could definitely be causing their pain? What's been done? What kind of workup's been done? We look into all of those kind of things. But I think really importantly, when we're talking with patients about pain and pain medicines, we really have to set expectations. Because we're not going to take away all 100% of pain with a pain medicine, right? What we've kind of learned with these opioid medicines specifically, there's really no evidence that after 3 months of therapy with them, there's any good evidence that they're useful or better than not taking them for pain. And when people get on really high doses of these medicines, there's a lot of side effects and risks of overdose and death. So from the beginning, we're setting expectations. If we're taking over prescribing for a patient who had somebody else prescribing their medicines before, if they're on a really high dose, one of our first conversations is we might be coming down on the dose, because it might actually help with pain too. High doses of opioids can actually make pain worse. So we might be coming down. We're going to be checking in with them pretty regularly. We're going to be checking urine drug screens. We're going to be checking some new things that have come out on the state level to make sure what they're telling us is consistent.
Tell me about, like, we have the evidence, like you said, if you have diabetes or high blood pressure or some other issue where you can get a blood work or something to show it. Does not pain raise your blood pressure?
Yes. Yeah.
So is that, if someone's here, that is one way, right? I mean, obviously they could just have white coat and just be automatically hypertensive,
sure.
But the fact that is one little thing, right? That at least you see, or is that sort of not even in the ballgame?
In acute pain, yes.
Okay.
Chronic pain, oftentimes no.
Because they're used to it now, right?
They're used to it, and it's
pain.
just a totally different type of mechanism compared to the acute pain syndrome. So really, when you walk when you're seeing a patient who's living in chronic pain and dealing with it, they often look, just by first glance, sometimes you can't even tell.
Oh, really?
Yeah, so it can be tricky.
So then when you're taking care of a patient, say, who had a problem prior to, and they've been rehabilitated because they've had issues with opioids, and now they're injured again. What happens? Is that completely off limits then because of that situation, or do you have to start all over and figure out what's the best treatment?
It's a tough answer. The first thing, it depends on the type of pain. Is it acute pain? Do they just fracture something, right? Do they have a bone sticking out of their arm? Obviously, we need to treat their pain. Moving forward, in that acute situation, we're going to be monitoring them closely, and we're going to be looking for other kind of behavioral signs to say, oh, is there an issue? Now, transitioning to chronic pain with patients who have had issues in the past, for me, majority of the time, those kind of medicines are off the table, and because there's no good evidence for chronic pain.
Yeah, because it's
our
still there.
Our first job is do no harm. So, kind of a risk-benefit analysis on every patient we prescribe these kind of powerful meds to. If the risk is too high, because we know where the benefit is, then I have an open discussion with them. But I'm willing to help, but just not with that type of medicine.
And I'd like your opinion on this, because we've spoken about this, and we just did our last session was at the Abington Community Library on opioid abuse, and talking to Dr. Dempsey about it, and Scott Constantini, and how these things happen. And it seems like it's this explosive, it's this epidemic, it's everywhere. Is that because for so many years pain necessarily was just associated with, it wasn't as, let's say, as popular, so to speak, or as out there? Now all of this stuff is happening with pain, and it's sort of become a little, sexy, so to speak, to have pain and go and get this treatment and get this done. All of these things are now adding up. Where did this come from? It just seems like I didn't even know. Excuse my ignorance. I had no idea what opioids were. I mean, when I heard it, I'm like, what the heck is it? Because I would use other terms for it, so I had no idea. So where do you, from a physician standpoint, think this whole thing has just blown up?
Well, I think it was a couple it came in, it was a perfect storm, really. So there was maybe late 90s, early 2000s, there was a real push for we have to treat patients' pain, right? Like pain kind of became the fifth vital sign. And that was fine, we want to address that kind of stuff. But I think with that, and at the time, our knowledge of opioids and our limited knowledge on them, based on what was out there in the literature about how dangerous they could be, we thought, they were pretty safe at the time. Well, we have to treat patients' pain. And it seems where that was part of kind of that igniting process for the rampant escalation in prescriptions that were, written for these types of medicines. So that was kind of the start of it.
And then it just came to a head.
Wow. It blossomed.
Yeah. Well, anything else do you want to show? I mean, Mark, take a look at the skeletal system, the spinal, and do you want to point anything out?
Oh, sure. So,
Chris, just so we can let the viewers see what.
Sure.
And that's interesting.
Let me grab this too. So, one thing, and I'll bring this up because we see a lot of patients in the office with chronic back pain, right? Again, there's many reasons to have chronic back pain, but one of the common causes as we get a little older is pain actually coming from the joints in the back. Okay, these are called your facet joints, and they're right up here on the model too. And just like you get arthritis in a knee or a hip, you get arthritis in these joints, and it often causes back pain. Maybe it could be one side, could be both sides. Usually pain at like the belt level can radiate down to like the buttock area a little bit, kind of worse with bending, twisting, those kind of movements, right? Maybe you feel okay laying down, but really any kind of activity, it really flares up. And this could be really limiting for patients. So one of the cool things that we do now and in our office and through kind of this kind of interventional pain medicine type approach is it's a twofold. First, we have to know if your pain's coming from these joints, right? To have a good treatment, we have to know what we're treating. So what we do is we actually do little nerve blocks, take 10 minutes, where we actually block little nerves that run in these little grooves here on this model. And they're actually right here. You can see this little nerve kind of running over top of this bone here. And you just little Novocaine type medicine like you get at the dentist. We take
you shoot it.
Well, we put it in, we do it under x-ray because the nerves are really small. We come in like this, we numb a couple spots, whether it's on both sides or one, depending where your pain is. You get up off the table and you should feel pain relief. So if that happens, we say, okay, we're on the right track. Your pain's coming from these joints. So if we've diagnosed your pain coming from these joints, instead of numbing these nerves up, we can actually heat them up. So again, under x-ray, there's no incision, nothing like that.
What's that called, Chris?
It's called radio frequency.
Okay.
Yeah, so instead of coming in like this on the nerve, we actually come in with a little special little needle like this.
And then
we lay it across the nerve, and we actually heat that nerve up. And when you kind of heat that nerve up, it kind of collapses down. And when the nerve goes from here to collapse down with heat, the pain signals can't get through. So it blocks the pain from going to your brain.
And how long does something like that last for a patient, or does it depend on the patient?
It depends on the patient, but for back pain, we say on average 6 to 18 months.
Okay.
Some patients, if it comes back, we just heat those nerves back up. But in the meantime, you're doing the things you like to do.
Yep.
We try to maybe get you into some physical therapy then, which maybe you couldn't tolerate before. So now we kind of set up more long-lasting relief. So.
Wow, interesting. Well, Scott. Did I say Scott?
It's the end of the day.
No, I mentioned Scott Constantini before, so that was on my mind. But Chris, thank you for this. This was very informative. Is there anything else that you want to have our viewing public, you want them to know that maybe I didn't ask you?
No, just, there's a lot of options out there for your chronic pain. If you've been managed by a doctor in the past and things have been going well, that's awesome. But for some patients, that's not always necessarily the case. So don't think that you have to live with it. There could be a lot of things that we can do that are kind of the new wave kind of things, and they don't all have to be revolving around medication.
Okay, there you go. Well, thank you.
Thank you very much. It was a pleasure.
So this was our sixth segment already, 6 months gone by, on pain management with Dr. Chris Connor, who is a physician here at Northeastern Rehab. So thank you again for all that information. So please take all of this, learn what you can, because it's very informative and very interesting, and you know a little bit more. Because I know people say to me, Laurie, I've watched that show and I've learned things. I'm like, that's the purpose of it. Get to know the doctors and what's actually going on.
Patient
that's a good thing.
education, that's the
That's
the biggest thing.
Exactly. So I'd like to thank you for watching. Again, next month will be our 7th, and it will be on mental health. We'll have Dr. Matthew Berger with us. And this is, again, the sixth segment on the Lackawanna County Medical Society's Public Health Education Series. We will see you next month, actually. Have a great month, and we'll see you soon. I'm Laurie Cadden.